Hello, everyone. My name is Varun Jain, and on behalf of the Communications Committee of the ASMBS, I'm excited to introduce this new initiative called SOARD Spotlight. This is an effort to not only increase the outreach and awareness around surgery for obesity and related diseases, or SOARD, which is the official journal of the ASMBS, but also introduce an interactive element by inviting some of the authors to share unique insights, thoughts, and ideas behind their work. This is intended to be a candid conversation that will hopefully supplement the weight of this text. For this inaugural session, I am delighted and honored to have Dr. Shanu Kothari, who is the Jean H. Hardin Stone Chair of Surgery, Professor of Surgery at USC School of Medicine in Greenville, South Carolina, President-elect of the Fellowship Council, immediate past President of the Southwestern Surgical Congress, and immediate past President of the ASMBS. Welcome, sir. Today, we are going to talk about the article titled Analysis of Enhanced Recovery Pathways for Bariatric Surgery, Preoperative Fasting, Carbohydrate Loading, and Aspiration Risk, a position statement from the International Society for Perioperative Care of Patients with Obesity. It's a very interesting article, which I had the privilege to go through and read. And as most people are aware about the ERAS guidelines and rationale around the guideline recommendations, I think especially for non-bariatric surgery, it's being more and more talked about with regards to bariatric surgery, I think, which is a very important element. So one question on the top of my head is as to how this collaboration came to be.
Yes, well, thank you for that, Dr. Jain, for that kind introduction. Thank you for putting on this inaugural webinar, if you will, or spotlight of First Sword. I'm really excited to see what the rest of these look like and what you've done with your committee work as well. Thank you for that. This product came from, there was about 5 or 6 years in a row where the ASMBS initiated a summit, if you will, held in Chicago every year, where we brought the presidents of every society we could think of where the disease of obesity touched their patients. So you can imagine that quite a bit that was. And we'd bring about 30 different presidents in. We would spend a weekend together, and we would share the developments in our society with them, and then they would share some of the challenges and opportunities within their respective disciplines as well. At the time, I was the chair of the Clinical Issues Committee, and as you know, we create many guidelines and position statements on behalf of our society. And about every single one of those years, you know, I'd walk across the aisle, shake hands with somebody from another society, and it would turn into a work product that ultimately got published. We've had the lipid panel, lipid study that came out of that. We've had the reproductive medicine paper that came out of that, working with the Hip and Knee Society on joint arthroplasty and obesity and bariatric surgery came out of that. And another one was this one, the ISPCOP, which is this, you know, Society of International Anesthesiologists dedicated to patients with the disease of obesity. And we first wrote one around post-operative nausea and vomiting, which was something that was near and dear to my heart too, because even when I was a resident many years ago, I did a prospective randomized trial comparing drug A to drug B to decrease post-operative nausea and vomiting following laparoscopic cholecystectomy. That actually ended up bringing a drug back onto the market back then. So I was really excited to be asked to be part of that initial project where we looked at reducing post-op nausea and vomiting in patients undergoing bariatric surgery. Out of that work product then came another request. They were so impressed working with us and seeing our pathway to production within SOARD and going from vision to published manuscript in such a short amount of time, they requested to do another one in an area that, again, is evolving around ERAS and the patients with undergoing bariatric surgery, which led to this particular work product here.
Very cool. Very interesting. So just again, off the top of my head, considering all the recommendations that come through ERAS guidelines, again, the ones that we apply to bariatric surgery, what was the idea behind specifically selecting these aspects, which is the carbohydrate loading, preoperative fasting, and how it pertains to aspiration risk?
Yeah, I think I would codename this paper the Mythbusters, because I think there are some assumptions that we all get to in our training that might be well-intentioned, but is there really data to support them or not? And so I certainly learned a lot reviewing this literature and being asked to be part of this as well. In terms of like, is obesity in and of itself really the risk factor for aspiration? The answer to that is no, but there are other contributing factors related to obesity, whether that be they've had altered anatomy, we've done bariatric surgery on them, or the diabetes and things like that can put you at risk. So I kind of codename this one like the Mythbusters, because it dispelled the myths that many of us just assume some of this data around aspiration risk, carbohydrate loading, where there was and was not literature to support these things.
Very cool. This is actually kind of leading into my next question, which is, what do you feel is the main challenge or the reason why there isn't a wider or more uniform adoption of these perioperative practices for bariatric surgery across the country? Is it purely to do with dogma, or is it just a thing that is more an issue of awareness that is slowly percolating through?
Yeah, I think it's probably the latter. As you probably well aware, you've seen that innovation curve for adoption, which takes like 17 years for something to actually catch on. You've got your cutting edge people, your early adopters, you're sort of middle of the road, and then you've sort of got the laggards. And so we all have our different ways as surgeons where we live on that in terms of adoption of technology. And so I just think it's going to take time and education and forums such as this novel one that you are hosting right now to continue to get the word out. I think collaboration is the key as well. Working with another society like this is fantastic, so that we can continue to learn from one another and cross-pollinate at our respective annual meetings some of this knowledge, and ultimately, like I said, transform for the better the way we care for our patients.
Perfect. I completely agree. I mean, this is one thing that I am slowly now learning, just starting out practice, that anytime we're working, and as surgeons, we are working with other disciplines, other specialties. I think having people who are equally committed and believe in the same ideas from the other specialties, and having them be stakeholders or champions, and then kind of working together is probably the best way to get everyone on board, and then practice whatever's going to be safe as well.
Indeed, absolutely.
Very good.
100%.
All right. So in going through the paper, there were about, I would say, as it was summarized, as 10 questions that have been addressed. So in your opinion, what would you say are, say, 3 key elements or aspects or take-home messages when it comes to addressing, say, these reservations or changing mindsets and eventually practices when it comes to our field, the bariatric and metabolic aspect of surgery?
Great question. I would say one is, obesity in itself is not a risk factor for aspiration. The carbohydrate loading per our standard cocktail, if you will, is not detrimental. Doesn't seem to, and perhaps is beneficial, but it's not safe to proceed with that in this patient population. Blood sugars with regards to that seem to be manageable, but probably are so transient, doesn't have to do with the downstream risk of SSI and things like that.
Right.
And the other would be, I would say it's okay to adopt dexamethasone for the use of prevention of post-op nausea, vomiting as well. And again, the transient rise in glucose is probably risk versus benefit, falls in favor of benefit for the patients. And then the one I found was probably the most novel, which I think I'd like to keep in my back pocket anytime we are delayed for surgery for whatever reason, was the use of ultrasound to assess the stomach contents, for our anesthesia colleagues who are leery or thought something they ate within some amount of time. And if it's the patient's story and the anesthesiologist dogma, maybe the answer is ultrasound to assess this. I think that would be a great tool in our armamentarium to moving forward for the patient of questionable stomach contents.
I love that. I found that very interesting, and I have to be honest, I haven't seen or heard the idea of that so far. So I'm sure the moment people are going to suggest or recommend that, is probably going to be met with some certain looks and questions, but I found that very interesting. And then makes sense as well. I mean, some objective evidence to support a practice, either for or against.
Absolutely, but we're going to need forward-thinking thought leaders like yourself to to do this and challenge the dogma. I can't wait till our anesthesiologists are walking around with point of care ultrasounds in the pre-op area. You see, there was a day we all thought ulcers were from stress too, remember? And
Yeah.
a certain person who went on to win the Nobel Prize whipped up a beaker of it, had to drink it himself, scope himself to prove that it was an infectious disease. So you can see how long it took, to go from you don't know what you're talking about to Nobel Prize, you see, for changing people's minds and the way we think about things. And so we start with, I always say we start with case reports, and then it goes to case series, and then it goes to small retrospective reviews, and then we get a collection of his body, and then it goes into a prospective trial, and then eventually we have systematic reviews and meta-analyses that help change our practice. And so it'll all start with your ultrasound that you order in pre-op on that patient.
Perfect. All right. Well, Dr. Kothari, any other pearls of wisdoms, insights that you'd like to share with the viewership before we finish?
No, just thank everyone for their interest. Thank you for your support of ASMBS and furthering our mission and distributing great content such as this with our journal SOARD. And look forward to further collaboration. And for you or anyone else listening, if they have an opportunity to collaborate with another society, whether it be at the society level or even at the institutional level, this is the best way to share knowledge and disseminate and move the field forward.
Perfect. Excellent. Well, I'd like to really thank you for taking out the time to speak with us, sharing your thoughts, perspectives about the publication and everything around it as well. It was really a pleasure speaking with you. We look forward to continuing this initiative, bringing the audience a more unique author insight, and continue doing this in the future.
Thank you for your interest.
Thank you, sir. You have a good evening.